Well, hello and welcome. Well, meningitis, new cocoa, to panic or not to panic. And indeed, what is it that brings about this strange variant of meningitis? We're going to have a bit of education to find out what at all meningitis is. And then we're going to go further to find out how to prevent it. Should we panic? And indeed, the communication. Has it been the usual and the cover, oh, we can handle it, leave it, and then until the last minute said, oh, no, we can't handle it? Because as I speak, 33 are already gone. Lost that we may never, ever regain. Is it going to come back? Who knows? But I have someone who knows all about it in the studio, and when I come back, I'm going to introduce him. My name is Nana Ansakwa the Fourth. This is PM Express, and you want to sit still and get educated. Doc, what's the situation now with this meningitis pneumococcal? Is that, am I saying it well?
Pneumococcal.
Pneumococcal. I beg your pardon, viewers. Meningitis pneumococcal.
Yes, let me say that we are handling a situation of meningitis. And meningitis is not so new in Ghana. Basically, if you're talking about diseases, you ask yourself, is it endemic? That is, do you have cases being reported, or it does not exist so that if you have one, it becomes an outbreak? Meningitis for Ghana somehow is endemic. That means that there are parts of the time of the year that you have reported cases in Ghana. So when you see one case of meningitis, it doesn't cause panic. It's like malaria. When you have a case of malaria going around, it doesn't create panic. As maybe if you're in the UK, that becomes an issue. The issue being that there are parts of the country that lies in the meningitis belt. And then during certain parts of the year, whereby the temperature, the disease in real sense relies on certain climatic features, like the temperature, the amount of rainfall, and the humidity. So there's a part of Ghana that lies in the meningitis belt that stretches from the west, from Senegal, going to the east to Ethiopia. So that is the belt. And normally
from Senegal to Ethiopia?
Yes, there's a belt.
Okay.
So that have unique climatic features. So during certain parts of the year, whereby you have very dry and very low humidity, then it predisposes one to have this disease called meningitis. Let me say that when we say meningitis, it's actually, you see, they try to make science easy. So meninges is a covering of the brain.
Okay.
So when you say itis, it's an inflammation of the meninges. So meningitis. So basically, if you say meningitis,
so itis is an inflammation of whatever you've added it to.
So you can have appendicitis. That's inflammation of the appendix. So meningitis, okay. Inflammation of the meninges, which is a covering of the brain. So this covering can be inflamed when you have infections.
Let me throw it out. This is a light one. At the moment, we have electricity billitis, which means our electricity bills have been inflamed. But that's just on a light note.
So when you have that inflammation, it could be caused by viruses, could be caused by bacteria, could be caused by fungal, could even be caused by chemicals.
But this covering, is it a fluid covering or is it a muscle covering?
No. It's a
gel.
It's like
phlegm.
What do I call it? It's a lining. Something
okay.
that covers the brain. So that because it's like in between the brain and then the skull. So when you have this inflammation going on, then it causes distortion of the normal distribution or the sphere of the lining. So meningitis, when we have the one caused by bacteria, they have three main types of the bacteria that causes this meningitis. We have one called Neisseria meningitidis, or NM. We have one called Streptococcus pneumonia, and one called Haemophilus influenza. So these are the three main bacteria that causes meningitis. What we have currently being predominant is the one caused by Streptococcus pneumonia, which is called the pneumococcal meningitis. In the time past, we used to have a lot of the type called the CSM, which is called by the Neisseria meningitis, which is the NM. And then a few cases, you may have the one caused by the H or Haemophilus influenza. The difference is that.
So which one is the cerebrospinal?
That is the Neisseria meningitis, the NM. That one has several types. You can have A, C, W135Y. That's the one which is common in Ghana that you call the CSM. But occasionally, you have this Streptococcus pneumonia coming in. So this year, a few weeks ago, there were reports of meningitis in Tyne, which is in Browns region. But as I said, because meningitis is somehow endemic, when you start having cases, you have certain thresholds that have been established that gives you a guide about what kind of interventions to take. So you have what they call the alert threshold and you have the epidemic threshold. When you say you have and these thresholds are set based in the context of the population of the locality. So when you have a population of like 30,000, which is normally a sub-district, then you're looking at reporting of 2 cases in a week. Then in that case, you are said to be an alert. When you have like 5 cases in a week, you say you're an epidemic. Then the other criteria is you're looking at a population of 30,000, 100,000. When you have 5 cases in a week, you are in alert. When you have 10 cases in a week, you are in epidemic. So those are the guides for you in managing meningitis. And let me say, I think at the intro, you talk about should you have to call WHO. WHO is part of the health system in Ghana. We work with them. So if WHO doesn't sit somewhere and we are also sitting somewhere, we are together. And when you talk about management of outbreaks of meningitis, there's a guideline which is written by WHO, by the AFRO. So Ghana adopts that same guideline and it has been adapted. So that's what we're using as a guideline. So whatever we are doing is based on the guidelines set by WHO. So these cases start coming in Tyne. And Tyne is in Browns region, which is not a typical meningitis zone. So normally Ghana, if you have a fever, you have a headache, and it's a neck pain, what do you think people will think of?
Malaria.
Yes. So the person who is ill thinks I have malaria. And it even influences the clinician. In medicine, you diagnose what is common. So people start having fever, headache, neck pain. This could be malaria. It's self-medicate. So it's a trend. So if you realize you're getting a broad base of people who are ill, that even the clinicians were also diagnosing malaria until we realize that we got to a mass. Then the alarm bell hits in. That when you have fever, headache, and neck stiffness, then you are talking about meningeal signs. So that's pointing to meningitis. Then now it moves the whole chemistry to another level. Then you have to do what they call a lumbar puncture. You take fluid from the back, and then you send to lab, and you diagnose. So in these cases, the organism they isolated was Streptococcus pneumonia. So the first cases were clear cases of Streptococcus pneumonia. Tyne district is close to Wenchi, and they tend to communicate. So some cases also came to Wenchi. But then you see, managing Streptococcus pneumonia meningitis, or pneumococcal meningitis, it is a bit different from managing meningococcal, which is mainly based on vaccines. So this one, the mainstay is early identification and then effective case management. So it means that the person has to come early and you give appropriate antibiotics to address it. But then wherever there's a challenge, if people report it early, and in some few cases clinicians missing it, then that's where the issue comes in. So when the alarm bells were sounded, then the goalpost changed. So now we are looking for meningitis. Clearly, you have an outbreak in Tyne. Then, in that case, you have to establish what we call the case definition. Case definition is like a set of clinical features that helps you to identify that one person has a disease that another person does not have. So in that case, you may be able to pick people who have the suspected cases and probable and confirm. So the cluster of cases that we have in Ghana, they are all not meningitis. It is a criteria that we have set to make sure that we mop up all possible cases of meningitis. So as I speak now, we have cases spread to Wenchi, Techiman North, Techiman Municipal, and then Tyne. These are the principal actors we are managing. But let me say that when this whole issue became like heightened proportions, then when you are doing the test of meningitis, you need a rapid diagnostic test, and this test is actually provided by WHO. That's what I'm saying, that we work with WHO, so it's not that WHO is sitting somewhere and we are also sitting somewhere.
I think that came in because there was a statement that said, oh, they could handle it on their own, and then later on said, oh, we've called WHO to come and help. So it didn't sound as if it sounded as if it was a different entity.
I think I speak to WHO almost every day. So we are together. I mean, look at the structure that we have in the Ghana health system. It's kind of fused, and it's a fluid system, so we work together. So apparently we are on track. The challenge is that we are in a season which is ripe for meningitis because of the suitable weather conditions for the organism to thrive. And let me tell you that the organism is actually in the throat of an individual. You may be having it once in a time, your immune system gets diminished, and then the organism which is there as a normal commensal becomes now pathogenic, so you start having the disease. And then when somebody is close to you and you sneeze or cough, then you may transmit the organism to him. Typically, the presentation is a fever, it's a persistent headache, and then there's neck pain that becomes stiff, so that the person cannot do like this. And then that's the classical signs of meningitis. If it's in a small child, you may have what they call the bulging fountain. We know the children have some like a hole here. It bulges out like that. So those are the classical signs that you look for in meningitis. So I think that for now we have a pool of diseases in Ghana that we say that we have outbreaks in Tyne and Wenchi. But I think that the health system is on top to address it.
How contagious is it?
Yes, as I said, it's in the throat. So as you sneeze, but for now, you are more than 1 meter from me. So let's say so if I sneeze, it doesn't get to you. It's droplets. So if you are very close, it's less than 1 meter, and I'm sneezing on you, and I'm coughing on you, then I can send the droplets to you. But it depends on the ventilation of the locality. It's a very airy place. As you sneeze, it blows out. That's why we're talking about the control measures. We talk about improved ventilation, so that things get better. The pathogens are blown off.
So far, 33 dead?
Based on our case definition. But as I said, I think I was talking about it yesterday. Let me say that we looked at our data in Ghana Health Service. From 2010 to 2015, averagely we are recording about 1,000 cases of meningitis. So that's why I'm telling you that it is not that the disease does not exist and it just pops out. It's a disease that can be. The difference is that this one, it appeared in a typical meningitis zone. So it changes the chemistry. When people in the north, the upper east and upper west, when it gets to this season, they are looking for meningitis because they've lived with it. They have a local name for it. But when it comes to a place like maybe Accra, people are not conversant with it, so they'll start thinking about malaria, though there's a clinical sign of meningitis. So that's the difference now. So 33 cases based on a case definition, but not all are pure meningitis. As I said, some are negative, but it's still in our line list because we want to make sure that we are able to identify all possible cases.
The two that appeared in the Ashanti region apparently were not.
Yes. I mean, apparently, it's good. You see, the heightened awareness makes people to look for it, and it's good. Maybe if this thing hasn't come out, it's possible those cases, they would not have done a lumbar puncture. They would have been diagnosed as maybe malaria or sepsis. We would have put on antibiotics. The person gets for and go home. But now, because of the heightened awareness, people are looking for it. So now you diagnose meningitis. By real sense, the organisms which were identified in Ashanti were mainly Neisseria meningitis serotype C. But we are talking about Streptococcus pneumonia. So there are different organisms here. So the outbreak we are talking about.
Do we have the vaccines or the medication for it?
See, currently, there's like the children, they have pneumococcal vaccine. Pneumococcus causes a lot of diseases, including otitis media, that's infection of the brain, the ear, causes pneumonia, the lungs can even cause meningitis. So the idea is that you give the children this vaccine so that they are kind of prevented from getting the diseases. Okay. But Streptococcus pneumonia has about 90 serotypes. The vaccines that have been developed is taking care of about 13 serotypes. So to be able to get effective vaccine, then the causative organism must match the vaccine. Okay. Otherwise, you will say, you'll be giving vaccine, you are not hitting the organism. Okay. That's why in that case, the best thing that you need to make sure you have done a serotyping. So in managing pneumococcal meningitis outbreaks, typically, vaccine is not the ultimate, unlike when it's meningococcal. Okay. That one is pure vaccine. Then you need to make sure that you have the kind of vaccine for either it's A, C, W135 or Y. So what we are preaching is early identification, early reporting, and effective case management with antibiotics.
So, but do we have the antibiotics for it?
Yes, let me say that the antibiotics are expensive, but I think that the government has been very proactive in that perspective. I mean, I was in Brown for last week, and we went for a consignment. And before we got, the minister and the deputy minister had brought another consignment of a branded antibiotic, very expensive. One costs 140 cedis. And then they brought about 1,500. When we were going, we also took 1,600. So you're looking at about 3,000 of antibiotics that are effective. Normally, when somebody has meningitis, the disease is a very invasive disease. So the treatment, you're looking at about 10 to 14 days. And clearly, the clinical outcomes is dependent.
3 a day, 2 a day?
No, you giving 4 grams or 2 grams daily for 10 to 14 days. Depends on
liquid, capsules, suppositories?
No, this one we are giving intravenous, IV.
Ah.
Yes, injection. Because the organism is not, it's a serious organism. So you need to hit it hard. So we went with a pack of these antibiotics. And today I was talking with the minister and the minister that their government is still ready to provide more. And let me say that all this is free. We have a challenge that the people who were having the disease in the initial stages, they don't have insurance. So they couldn't go to health facilities and they were held back. So initially for the time and the rest, the MP and the DCs were actually paying and getting them registered. But I want to make it point clear that treatment for meningitis is free.
Whether you have a card or not?
You don't need a card. It's an emergency situation. Emergencies are managed free of charge. Mm-hmm. So we are saying that you have a fever, you have a headache and neck pain, go to a hospital. If it's diagnosed as meningitis, you'll be treated free of charge.
And if, let's say, in 10, you do the spinal fluid extraction, where is the nearest lab and how long before they can say it's positive or negative?
Yes, normally we have several laboratory processes that you can do. When you do a lumbar puncture, you stick in a needle, yes, and you get the fluid. A typical district hospital can do a basic test called a gram staining. So you can identify whether it's a gram positive or gram negative. It gives you an idea of the kind of causative organism. So that can be done in most district hospitals. The further one is to do a culture. That one clearly isolates the organism. Then the culture takes about 48 to 72 hours to grow the organism. But the other rapid tests that can be done, the one that commonly done is Pasteur-Rest. It's an agglutination test. And that one, most of that kits are provided to us by WHO. Every year, before the year starts, we have a whole list to send to the WHO that we are preparing for meningitis. These are the things that we need. So that one, you put it on the slide and then it clots. So it tells you that this organism is in. Then there's also an ultimate one called the PCR. Mm-hmm. Currently in Ghana, we do one in Tamale. That will actually confirm that this is the organism. So there are clear laboratory procedures. What is important is the clinician to suspect that is meningitis. They need to do the laboratory testing.
Some of the panic out there was that they didn't have vaccine for this strain. So I mean, it's reassuring to say that you have more than enough.
Yes, it's not a vaccine. What you have is antibiotics. Because clearly, as I'm telling you, you see, you can use vaccines to manage pneumococcal meningitis, but that's an alternative. You see, unlike meningococcal, which is purely vaccine driven, because as I said, if your serotype does not match the vaccine, then it doesn't yield any result. So clearly, what we have is that we have effective antibiotics. It's called ceftriaxone, a very high level 3rd generation cephalosporin antibiotics, and then the government has gone ahead to buy branded. So the branded hits you very fast. So if you report early, clearly after 10 days you are going home. So there are several districts now that have reported a number of cases and nobody is dead. Like Sene West, in Kranza South, nobody is dead now. So it's about early reporting and then effective clinical outcomes.
Let me catch up with some messages, and then those at home who want to know more, you send your messages to 0560 800 000, 0560 800 000. This one says, please, I want to know the cause, signs and symptoms, and the first aid management for meningitis, so that those of us who are far from health centers to start the first aid. Simon Peter from Akbozome in Soklazi. The second one says the health sector will continue to explain themselves when there is an outbreak of disease. Why can't they pre-inform us before it comes? The white man could manufacture disease and after manufacture drugs months after to cure it in order for them to get money. Let's pray to God for him to have mercy on us. Who even names the sickness? Who even names the sicknesses? In 6 months' time, another disease will come from Kofi Akwamu Edumasa. Oh, I see. Oh, that's my town.
I think yes. So is your friend.
This one says, good evening. I understand the infection is transmitted through sneezing, coughing, etc. I would like to know what the probable cause would be for how the bacterium ended up in the throat of the first victim in time. Bismarck, upon assuming in Legon. I'm going to take a break, and then when I come back, I'm sure Doc is going to answer your questions for you, but the number is 0560 800 000. Meningitis, pneumococcal, should we panic or should we not panic? And keep your messages coming in from 0560 800 000. I think Doc is going to answer the 3 questions before we move on. So Doc, I think the cause and signs and symptoms you have elaborated enough.
Yeah, I think that's maybe to just add on to the symptoms, as is fever, headache, neck stiffness, you have convulsions, there'll be confusion or coma, what they call the altered consciousness. Then for babies, you have a child who is lethargic, maybe irritable, you just cannot sleep. Then you have this anterior frontal which is bulging. So those are some of the features that you look for in meningitis. Somebody wanted to know, how did the bacteria get into the throat in time? You see, there are 2 ways. You can have an individual who has the bacteria within their throat, and it's there normal as a commensal. Then the person gets some infection, or the person's immunity goes down. Then that normal bacteria now becomes pathogenic, so it causes disease in that same individual. That's one. Second one is, person doesn't even have the bacteria. He's now exposed to another individual who has the bacteria. That person might not even be ill. He could be a normal carrier. So when that person is close to you and is sneezing and coughing on you, then you can transfer. So that's the way it is. So for the time case, it's not very classical, but we could see that the Wenchi case for somebody who...
So sharing a spoon, kissing, yes, all those stuff.
Yes. So if the person has the bacteria, and then there's that exchange, you can also get it. So the time one is not very clear how we got it, but when based on our investigation, we could see that somebody came from north. You know, the people from north are kind of immune, so they can come and then introduce the bacteria to you. So we are thinking it's either somebody came from the northern part of the country, they introduced it, and the person was.
And quickly before I go to the first, who even named the sicknesses? All these funny names. Who brings about that? Briefly before I go to the phone. How do these scientists, come about with all these names?
The names. I think that we look at the part of the body and based on how it's presenting, and then you give the name to it.
So
to make it easy to learn medicine.
I see. Let me go to the phones and speak to Dr. Gilbert Benako, President of Coalition of Health NGOs. Doc, you're welcome.
Hello.
Hello, Doctor, you're welcome.
Thank you.
Very good.
Good evening, everybody.
Good evening back to you. Well, we're looking at this new strain of meningitis which is in the system. The general public sentiments are that maybe, the Ghana Health Service may not be able to contain it. We may have to look outside for help. Then their concern was that why weren't we informed a bit earlier so we can all, those who got infected could arm themselves. Were they taken by surprise? But you are obviously a health NGO, so what are your concerns or what are your advice for us?
Yeah, thank you very much for giving us the opportunity to also show our commitment to the whole outbreak of the pneumococcal meningitis in the Brown and now to other parts of the country. If you remember, I was interviewed on the Joy News about a month ago, and I did indicate that the initial attempt by the Ghana Health Service was very great because they had moved to the community to ascertain the facts on the ground and also to come out with strategies to be able to manage it. And I recommended them for such initiative. But after 2 weeks or so, they relaxed in the process. Remember, I mentioned 2 issues that the coalition of NGO we are concerned. I said, one, the clinical aspect should be tackled to actually find out the real case and how it can be managed or treated. And 2, I talk about the public health aspect, which is more social intervention, that they needed to scale up the approach in which communities must be prepared, people must be aware, messages must be well relayed back to the communities. So that is our concern now. I understand WHO is around, but we have also moved around in the districts where it's moving very fast into. And we have assessed the situation from our civil society perspective. This is what we have noticed. One, there has not been adequate education in the communities about what is really pneumococcal meningitis. And I said this afternoon when I met the Deputy Director of Ghana Health Service in the Brown that we need to have local content messages to communicate effectively in the communities so that we can generate demand for people to visit the health facility in the case of any suspected case. 2, we need to increase the capacity of our disease control and other health allies so that they can be able to report and intensify their surveillance system. 3, we need to get WHO technical support because it's done elsewhere and WHO has the experience. So we need to get WHO immediately for both technical and financial support to help us come out from the situation. And 4, we have not involved civil society very well. And I'm not only talking about the coalition of NGO in health, but I'm talking about Nananum I'm talking about the other civil society groups. Ghana Health Service need to sign quickly an MOU with all the media houses in the country so that they can apportion an appropriate airtime for the health personnel to talk about pneumococcal meningitis and how it can be managed and the responsiveness so that people can be more aware in a very friendly and local content. And that is our concern. We think that as much as they have approached the issue, we think they should be more proactive in working.
Dr.
That's why now you see that it's now moving from district to district. And by the records this afternoon, we already have 13 districts in Brahafo who have recorded cases, and in some cases suspected cases. Doc, and that is not very good for us.
Doc, please,
we are encouraging Ghana Health Service. We know they can do a good job. We know they know what to do.
Dr. Benako, let me come in here, please. You were talking about the WHO technical support, but they work hand in hand. So what other support are you talking about?
You see, there are procedures they need to follow immediately to get WHO support. You know, these are government to government dealing with. And I know the Ministry of Health, Ghana Health Service, they already know the protocols, how they should do it. But we are concerned that the process must be speed up so that immediately, if there's a need for a vaccine to be brought to the country, WHO can recommend and ensure that it comes quickly.
Okay, Dr. Benako.
If we already have vaccine in the system that can manage the situation, WHO can easily advise. If you have vaccine but they are expensive or costly that Ghana cannot afford, they could provide both technical and financial support.
Dr. Benako, hold on. Let me bring Dr. Sedu in here. Doc, I mean, I want that clarification of WHO. I mean, what more? What's doctor saying about? Because as far as I'm concerned, you know, you work hand in hand.
Yes. Let me say that. I don't know what pertains in other countries, but for Ghana, we work together. You see, when we were going to the field, you know, I was in the field with a team. Originally, we were even supposed to go with the WHO team. And at that time, they were having a retreat. So we were always keeping in close contact, giving them what is going on, because also analyzing it as a group, as a retreat for the year. And the outbreak was one of the issues.
Are there certain protocols that you have to do that will give you special partnership?
No. Well, as I speak now, I think I've spoken to the DPC, who is a technical person, today about 20 times. Because I even tell them where they should go. They are on the phone, they are now. So I told them they should go to Sene West, they should go to Nkranza South, because I saw that cases have gone up. I told them they should go to Tyne, because Tyne, you look at the epic curve, the cases stopped for about 10 days, and so cases came. So we are together. And yesterday, you know, we had a technical meeting, which was hosted by WHO. And in the presence was the country rep of WHO. He chaired the meeting. So, and we had a clear roadmap about what to do. So the WHO issues, I don't know. But what I'm telling you is say that what we put across the WHO yesterday, or no, say 5 days ago, was that the test kits, which are called the PASTORES, the rapid diagnostic test kits, were provided by WHO. It was getting finished. So we put pressure on WHO that we need it. And even our deputy minister had to call and arrange with the AFRO headquarters. So yesterday when we met, they gave us 3 packs. And 1 pack does 25 tests. So currently now, what we are hoping for is to get a confirmatory test. You know, I told you there are several tests that you do. You do the PCR, you do the gram stain, you do the PASTORES. There were issues of the PCR, which we are in touch with WHO, and hopefully tomorrow we start doing it in Noguchi. Noguchi has the capacity to do it. There were issues about reagents. So WHO, I think we've managed other issues. You know, there's another issue about, I don't know, but for Ghana and WHO, we are in the same boat. We are together. And the guidelines we are using is WHO guideline, which Ghana adopted. So Ghana and WHO, I don't know.
So there isn't any issue between the Ghana Health Service and WHO. Have I got Dr. Banako on the line?
Hello.
Hello, Dr. Banako.
Yes.
As you could hear from Dr. Siedu, I mean, as far as protocols and relationship concerned, they are, quite tight with WHO.
Sorry, the line is saying I can't hear you well.
Did you hear Dr. Siedu's remarks?
I didn't hear him well because the line is thin.
Okay, let me repeat what he said. I mean, he's saying that the guidelines and everything that they're using are, WHO guidelines, and as far as relationship and protocols are concerned, they are, there's nothing else to be done. They're very close.
Yeah, I mean, I did not say they are not following the WHO guidelines. What I'm saying is that the process is still very slow. That's one.
Okay.
Two, they need to move away from the response now to more commitment to maintaining zero case transmission. And that is what we are interested in. And the strategies they are putting in place, we are asking that they should show more commitment, involve more people into the strategy. One, we need to advocate. Two, we need to communicate. Three, we need to ensure that we get feedback that inform planning. And then this can now inform all the procedure that they are using. I'm already on the ground. The whole of last week I have been in the communities. This week I've been in the communities. So what I'm saying is that I have visited some of the districts. In some cases, the situation was going down and later on they shut up. So what I'm just trying to say is that we have cases that were managed in one community, then it escalates in the nearby community, then it moves to another district, then it moves to another region. Because we are not tackling it comprehensively. And the WHO guideline means once the issue is identified, you will know the situation, it can be managed there, but you focus in the other areas so that it doesn't escalate. And that is why I'm talking about that. They have not approached that with urgency, and they have not approached that with financial and resource-wise. And we are advocating that they should involve more people in the district task force. They should involve more people to support in the process. And that's where we can minimize the spread. At the same time, we provide the treatment for those affected.
Okay, I'll put that to him. So
yeah, I think that we agree with the suggestions made by Dr. Benaku. I think that we were on the ground. I mean, one thing that was clear is that the messages were focused in the areas that were affected. And we thought that it must be more widespread than it's supposed to be. And luckily, the government has brought some support because that involves a bit of money to do that. And I think that what we do is that, for every district, there's what they call the District Emergency Management Committee. And that one is supposed to be chaired by the DCE. So that group has the oversight when there's an outbreak, which the health is just the technical support to that group. So the DC now takes charge of all health activities in the region, particularly in the district, to promote education, so that you have the use of the vans. We know that the message hasn't got as much as we would love to go. So I think that's why we take his advice about how to involve more stakeholders at the lower level. And then when it comes to the issue about our surveillance people, we have given them the necessary alert that clearly now, you see, what happened?
Like everybody else, are you understaffed?
Is that?
Like everybody else, are you understaffed?
No,
surveillance team?
No, we are not. You see, what we are saying is that Ghana Health Service runs a system that goes further down to the community level, where you have the chiefs. The chiefs is where they have the community health nurses. So we are saying that the community health nurses now should be on board in the areas of surveillance because they are closer down to the communities. For surveillance officers, they are not so much, but the community health nurses are now sensitized that they can now be able to identify the cases as early as possible. So that's what you have. The technical support issue about WHO, I think we are together, but WHO is on the field now. Hopefully they are coming back on Thursday for us to review, because we came with our findings. They're also going and coming on Thursday. You have another joint meeting on Friday to see how best we can reconcile our recommendations. But As far as I'm concerned, Ghana Health Service and WHO are together in this outbreak. Okay. So that one is.
Doctors, striving to achieve, zero case transmitting. If we know the areas, is there vaccination before time? Can you do that, or it's not allowed?
No, you see what you do is, as I said, if it's meningococcal, then you do vaccination.
Okay.
Pneumococcal, the mainstay of management is not vaccination, but in few cases you can vaccinate close contacts. So that's why CDC and then WHO is helping us to do the serotyping, and now Noguchi has also come in. So I can be sure that the organisms causing this outbreak are the same types that are in the vaccine. So hopefully, within a matter of few days, we will be able to identify that is this the same organism which is causing the outbreak, which is in the vaccine, then it can be targeted. But for pneumococcal vaccination, it's not done widespread, unlike the meningococcal vaccination, which is done widespread. So I think we've taken the recommendations that he's given about the local content messages, because we think that the message must go very down. And this one other challenge was the issue about financial access. People do know that the treatment is free. You get, and at that time, initially, before you are going to buy one drug for 140 cedis, then you better stay at home and take your local medication. So now we are pushing more the message that come early and it's free. Come early and it's free. And then we are also making sure that it's about fever, headache, and neck pain. So that what we expect to see is that we expect to see an increasing number of cases. Now that we are pushing the message. But then we expect to see less people dying. Over a period of time, the cases will come down, and then there will be no death.
What's the incubation period?
It's about a maximum of 10 days. So it runs from about a day to 10 days. So the averagely, you're looking at 4 or 5 days. So if you're exposed to the bacteria, depends on your immune system, and depends on the dosage, you can run for between a day to 10 days. And then the course, does you have a disease, how long does it run for you are whole? It's also about 10 to 14 days. So that's it. But let me say that I want us to see ourselves as advocates in the fight against this meningitis outbreak. Because nobody wants to be ill. It affects the country in diverse ways. So as you said we should sign an MOU. I think Joy or Multimedia is a big player. Help us in the fight to address this meningitis.
We've given the platform, and the fight is on here. But I've got some more messages. 0560-800-000, 0560-800-000. Just before I go to the break, let me catch up to some messages. The disease is absolutely real, and citizenry must be well informed through Department of Information Services across nationwide. I have the doubt that it is only limited to certain regions, since looking at its sporadic nature, it could spread to other regions. Let's be cautious. This is Harry from Odumasi Krobo. And then this one says, Doctor, apart from the means of transmission that you have mentioned, i.e. sneezing, coughing, etc., can the hot weather also cause it, as we are made to believe in the north? Muniru Abuabo in Tamale. Doctor, I sneeze a lot, especially when the weather is cold. Is it from meningitis? Nana, for all of us to play it safe, we must all endeavor to avoid kissing, hugging, sharing cutleries, protect ourselves when coughing or sneezing, etc. Ghana Health Service must find the cure now, so that this disease should not become another HIV. This is McLean Ajamaga from Gowari in Bongo. Ministry of Health always come out to defend any disease. Never try to accept these causes of outbreak of meningitis, which killed 33 people. Should the people all die before action will be taken? They need to educate the people on the disease. Frank Dadzi from Japan. And then the last one before I go for breaks is, please, Doctor, can we have detailed documentary information on conditions like these to help educate ourselves? Thank you. Asibi in Bolgatanga. Stay tuned, we're coming straight back. Well, thank you very much for staying, and I hope that you are catching up with the education as to what to do. So definitely, there is no need to panic. Yes, the disease is here. There is the belt. They've always suffered it, but a different strain has come in. And as always, the diseases will come in and go. And we thank Doctor for the education. Just next time they should be ahead of the media. That's all. Doc, there were a couple of questions which I don't know if you wanted to.
Yeah, maybe. I think one wanted to know whether sneezing is meningitis. I think more is an allergy. You know, the body has a way of defensive mechanism. So it's like certain things get into your nostrils. You want to get it off, you have to sneeze. Or like something's in your throat, you have to take it off, you cough. So those things are defensive mechanisms that you have. So that is not meningitis. I was telling about the weather is a predisposing factor that enhances you to get meningitis. So the weather does not really transmit meningitis. So as I said, if you have a very high temperature, I was telling earlier on that, have you ever been to Burkina Faso? Hot weather. So that's how they always have several cases of meningitis there. Then a lot of dust.
They have meningitis in the UK, but I mean, that's quite cool.
Yeah, what I'm saying, but they don't have that kind of large. So you have factors that promote it. And what I'm saying, the factors that promote meningitis are low relative humidity, high temperatures, and then the dust. Because normally when it's very dusty, you tend to have cracks in your throat. That's why we advise that you make sure that you're taking a lot of water during this time so that you have a cool throat. So hot weather itself does not cause meningitis. Because as I said, the organism is in the throat, or it's like a commensal in the throat of an individual. It can become pathogenic, and then it can affect the individual himself, or it can pass on to another individual. So that's the way you get a disease. What other questions did I have?
Can we please have detailed documentary information? I think that's what we are doing now. And no, I think these are the main ones. Doctor, apart from the means of transmission that you mentioned, cause of belief. No, that's about it. So, you know, it's now moved from Tame, from the bronchial halfway, and it's spreading. So who's spreading it? Since it's not that contagious, how come who's moving about in the regions?
Yeah, I mean, today I was talking to one professor, and we were discussing. I said, why is that thing moving? And he said, electricity no get like power they carry on. You see, because we move around, and time and Wenchi are close. So I can just, I can move from here to this Atabraka, and then I have the organism in my throat, and I send it out. Because now the world is global, everybody is moving around. So as you move around, and they have the right kind of climatic conditions to promote the transmission, then you are likely to have the disease. So what we are preaching, is that let's see the early signs of the condition. And then we also look at the individual. Like if you are sneezing or coughing, make sure you cover your mouth or your nose. Then when you are also close to somebody who is coughing or sneezing, you make sure you go away. When you cough or sneeze, make sure you wash your hands thoroughly so that you don't soil the clothing of others. Then make sure you drink a lot of water.
How strong is the bacteria once it comes out?
It's not very strong. It's not very strong. That's why we are saying that. So good ventilation also promotes it. So one challenge is that if you are in a congested room and you are sneezing and coughing, then there's high likelihood that you're going to infect everybody in that place. So for this time of the year, though it's cold, we expect that you open your windows, that if someone is coughing and sneezing, the air blows it away, then the chance of getting infection is minimized. So we are saying that the Ghana Health Service, Ministry of Health, is committed. Because I think that nobody likes an outbreak. I'm sure by now that we need something different. So outbreaks is not something anybody likes. We are saying that we should all help ourselves, that health should be a property of both the giver.
So does it mean next year by this time, when the weather gets hot again, there's a new variant that we have to be watching out for?
No. You see, I have been involved in 2 other outbreaks. One was in 2008, in Ashanti region. Ashanti region is not a typical place that you have outbreaks. It was one very forested place in Ashanti, Ofinso or Fuasi sub-district, a very dense forest area. They had an outbreak. What happened was that somebody comes in from the north, introduce the bacteria into that locality, then it starts an outbreak. And then when they meet, like funerals or whatever, that small community, they share and go away. And that one happened in Obuasi 2011. Also, you know, climatic change is causing a lot of diseases to occur now. So I think that Ghana now, you know, most of the adverts are saying if you don't get well, after 3 days, report to your health facility. I think it's a bad advert. People take medication and they stay for 3 days before they go to the hospital. And for meningitis, maybe you'll be dead. So if you look at the first early 5 cases, they all died within 24 hours at the hospital. So we are saying that
because they stayed home too long.
Yes, because I'm sure I'm feeling fever, headache. It's malaria. I take attention.
So when you catch it and from when touch wood, you know, it doesn't happen, you pop off, what, 10 days?
If you don't come early, then the chance of survival are minimal. But if you go early, as I said, within a matter of 10 days or 14 days, you are off and you are going home. So we are stressing on early reporting. Early reporters are saying that if you look at our expectation.
No, but from catching it and from dropping dead, what are we looking? 2 weeks?
You can. Everybody has a different immune system.
Okay.
So some can die a day, some can die 2 days. It depends on. But one thing is dependent on your immune system, and then the dose of the bacteria at a point in time. So those are factors that can determine how long you can take to get a disease.
How long? If I cut your sneeze, how long before I start feeling the stiffness? 2 days, 3 days?
Yeah, that's the incubation period, and that's why I say it's run from a day to 10 days.
Oh dear.
Yes. So if you're exposed to the bacteria, it can take within a day to 10 days for you to come out with the symptoms.
I see. And as soon as you get the symptoms, rush to the hospital.
Yes. As soon as so we are pushing, as you said, we are saying that we want to join the media, be on our side, so that Ghanaians are well and healthy. Fever, headache, neck pain or neck stiffness, meningitis, go to hospital. It's possible it's not meningitis, but let's go to hospital. Treatment is free.
Well, I think that's what time will allow us today. So that was Dr. Franklin Esiedu-Bekwing, Head of Disease and Surveillance, Ghana Health Service. And we have pretty much gotten enough information of what to do. But as soon as you feel stiff neck in the head, headache and dizziness.
Headache, fever and neck pain.
Headache, fever, neck pain. Boom, straight to the hospital, get it checked. And it's free, whether you have an NHIS card or not, it is free. Thank you very much. Thank you for watching. Tomorrow we'll be back to do this all over again.